This should be a really quick video. We don't need sterile gloves for laceration repair, right? I mean, we've known that for a long time now, right? In medical school, I was told first to use sterile gloves for all lacerations. And then in residency, I was told the exact opposite. The sterile gloves were absolutely not needed when repairing lacerations in the emergency department. This was one of my very first exposures to dogma busting in medical education. And unfortunately, the old dogma was really just replaced with new dogma. Strong statements that are made to learners with very little to back it up. No discussion of the nuance, no discussion of the evidence other than sort of a hand waving. Don't worry, there's RCTs that prove this. And I probably entered residency at the most dangerous point for this kind of transition for this topic. I was there a few years after the big study. So I missed all the journal clubs, the real discussion of the paper, and instead I got the oversimplified one-liner. And I think we do this all the time to our learners. In the year a paper comes out, we discuss it ad nauseum. We discuss all the complexity. But if a learner comes by 3 years later, they just get that single statement. This is the way things are done. We end up replacing old dogma with new dogma. And I've seen this over and over again, whether it's our discussion of one-to-one-to-one transfusion or TXA in trauma, really any topic where there's a big publication. Learners in the year that the paper was published will dissect that paper and they'll hear all about the nuance. But then after that, all the learner gets is a one-liner. Something like, oh, don't worry, one-to-one-to-one is the standard of care. It is proven. And that is how dogma is formed. Now, getting back to the topic at hand, I guess, pun intended, the paper I'm talking about that made this huge change in the dogma for sterile gloves is Pearlman 2004. And the authors here are actually all friends now, colleagues in Toronto. It's a multi-center RCT that included over 800 emergency department patients over the age of 1 with uncomplicated lacerations. They did exclude patients who were at high risk for infection, so things like diabetes, renal failure, immunosuppression, asplenia, cirrhosis. That's interesting because that was completely left out of every discussion when I was taught this topic, although to be fair, I'm not sure how relevant those exclusions are. The primary outcome is wound infection. It was assessed by a questionnaire that was given to the patient to be given to their family doctor at the time of suture removal. And if they didn't get that, they ended up calling the patient. And it's not surprising at all, but less than half of the questionnaires were actually filled out. But they actually did really good. They got great follow-up. They managed to reach 97% of these patients, either by that questionnaire or by phone. And based on that, infection occurred in 6.1% of the sterile glove group and 4.4% of the clean glove group. No difference. For a study in emergency medicine of wound repair, this is a big trial. But obviously, we can't exclude tiny differences between the groups here, and it's by no means a perfect trial. Selection bias is a potential issue. Phone follow-up is not perfect. The providers can't exactly be blinded, and that's probably the big one, right? You can imagine that if you really think that sterile gloves are important, you might treat the patients when you're not wearing sterile gloves a little bit different. You might do more to clean that wound. But overall, given the subject matter, very good trial. Definitely not strong enough for the strength of the opinion that you'll sometimes hear on this topic, but very good trial. There is some other research out there that I found fascinating. My favorite two, I think, are two trials, Bodiwala 1982 and Matra 1986, that compare sterile gloves to no gloves at all. I can't even imagine going near a wound without gloves. But that's the world. The early 1980s was a very, very different place. Both trials, relatively small, obviously are going to have their problems, but for what it's worth, the infection rate was the same in both trials with or without gloves. There's another trial done by a single doctor. I like it. This is just a guy in his family medicine practice, randomized 50 of his own patients. He did it by pulling colored beads out of a bag to either have a full sterile laceration repair. Picture, he's describing OR type sterility to no gloves at all. But he did wash his hands beforehand, so that's good. Despite being his own family practice, he only had follow-up data on 43% of the patients, which is a little bit weird. Sorry, 43 of the 50 patients, which is still weird. Infection occurred in 10 out of 22 of the sterile group, which is insanely high, and only 3 of the 21 in the no gloves group, which is a huge, huge difference. It almost looks like sterile gloves cause infections. Again, like this is a single guy in his office. By far not a perfect trial. We don't need to deep dive all of these trials, but there's one thing that I wanted to point out about this particular trial, because it's going to come back in a few future videos. 50% of these patients apparently had wound infections, right? Which, that sounds like a big number. But less than 50% of those quote-unquote infections were given an antibiotic. So what the heck does that mean? What is a wound infection that doesn't require any treatment at all? Is that a wound infection, or is that just some erythema in response to the sutures? I don't know. I don't know what a wound infection that requires zero treatment really is. And that comes up over and over again in these trials, telling you that wound infection is a pretty subjective outcome that may not mean what you think it means. So, we have 3 studies that say that gloves don't help at all. Like literally no gloves, just bare hands. But of course, please, please, please do not repair lacerations without gloves. That is gross. But for our purposes, I think it's really interesting to know that there isn't even good evidence that sterile gloves are better than bare hands. In 2002, we had another big multi-center RCT to follow this all up. This is Zwaans 2022, basically 2022, basically replicates that Pearlman study. 1,480 adult patients with lacerations requiring sutures in the emergency department randomized to either having their wound closed by a doctor wearing sterile gloves or non-sterile gloves. All wounds were irrigated with tap water, and that's probably going to be the next video, but I don't think that the irrigation approach matters very much here. Unfortunately, the trial was supposed to include more than 2,000 patients. They stopped early, and I found this really interesting because apparently they just didn't see lacerations in the emergency department anymore. Something about merging the emergency department with local GP offices, which is a fascinating topic to explore more, but we are potentially underpowered here. The wound infection rate with sterile gloves was 6.8%, 5.7% in the non-sterile group. So despite being stopped early, this is the best evidence available, and it is very much consistent with no difference between the 2 gloves. On its own, I don't think this emergency literature is perfect, but at least the trials are all saying the same thing. But even more than that, I think there's a pretty good theoretical basis that has led to us all abandoning sterile gloves, right? The argument is, unlike surgery, where you start with this like perfectly sterile environment, all of the wounds that I'm seeing are already contaminated. My gloves, whether they're sterile or just clean, are almost certainly cleaner than whatever cut the patient in the first place, the ground or the knife or the saw blade, right? So if you want to know the impact of gloves, it might make sense to focus on surgical procedures where like skin is cleaned perfectly before the laceration was even made. In that sense, like the contamination from the gloves might really matter. So that's the best case scenario for sterile gloves. And there is actually a fair amount of data, mostly out of dermatology clinics. There's Brewer 2016 is a systematic review meta-analysis, over 11,000 patients, 13 studies. And the rate of postoperative infection was exactly the same, sterile gloves or clean gloves, 2% in both groups. Now, this is a mix of dental surgery and Mohs microsurgery, so it's a little bit weird. Looking through the subgroups, look, there's no difference. So I think that's probably the strongest evidence that even in sterile procedures, the glove type doesn't matter. There's one last thread of evidence that I think was interesting, that I think helps clarify this issue. Clean gloves are mostly sterile, right? Just look at what's on gloves and if there's bacteria present or not, and that can tell you a lot. Obviously, factories are not contaminating their product on purpose, right? They're not sending out gloves and smearing staph all over them. So you can sort of expect that box of gloves to arrive at least relatively sterile. Now, I think the big concern is that, you get that big box, and so the more people reach into it, the more it's going to become contaminated over time. So there was one really interesting ICU study that looked at that issue by culturing the very first set of gloves removed from a box, just leaving the box in the normal ICU setting, and they cultured a set of gloves from halfway through the box and then the final 2 gloves in the box. This is Rosoff, 1993. And despite being unsterile gloves, half of the gloves were sterile at all points. That means the other half were not sterile. There was some bacteria on them, but if you look at it, there's very low rates of contamination, and the bacteria that they found had a very low risk of causing infection, very low pathologic potential. So I think all of those streams of data come together. It provides a really strong pathophysiologic support for the findings of the RCTs, right? Sterile gloves cannot possibly reduce the risk of infection if they're compared against other gloves that are basically sterile anyway. But I think it's reasonable to still use some judgment, right? In many ways, right? A brand new box of gloves is probably pretty close to sterile. But if you get that ratty old gloves that looks like it's been dropped on the ground, 13 times, maybe used for an impromptu game of soccer around the emergency department, that may not be as clean. And similarly, the first study at least excluded some sick patients with those immunocompromised. So what's our bottom line? Simply put, clean gloves are fine. The two biggest trials we have, both Pearlman and Zwaans, have very similar numbers. And although both have potential sources of bias, there's absolutely nothing to make us think that bias would push these results in one way or another. It's impossible to exclude a tiny benefit in one way or another, but I think we can be very comfortable that basic, clean gloves are good enough for most routine laceration repairs. But don't be black and white about anything in medicine. Judgment should always be used. If you're looking after a patient with significant immunocompromise, or if you're repairing a wound in a very sensitive area or infection-prone area, I'm not going to fault you for deciding that is an area that sterile gloves might make a difference to you. And please, despite all the evidence we discussed above, please wear gloves while you're repairing wounds, even if it doesn't seem to affect the infection rate there. For the vast majority of patients I see, I just grab a pair of gloves out of that big communal box, repair the wound, and get them on their way. That's all for this one. As I said, it should be a short one. If you want more videos, either about laceration repair, because I probably have 4 or 5 more of these coming, or any emergency medicine topic, make sure you're subscribed. Until next time, take care.